We'd like to call the next speaker now, Dr. Anjali Khadia. Dr. Anjali is here, and she'll be speaking on double flange technique in iridodialysis repair. Dr. Anjali is a ratified member of AIOS. Dr. Anjali, please.
Good morning, everyone. So my presentation is double flange technique for iridodialysis repair. I have no financial interest in this presentation. So challenges in iridodialysis repairs, it's require high level of surgical experience and skills, and majority of our ophthalmologists are not trained for performing the conventional iris repair because iris is very thin and delicate and take longer duration. So here we will demonstrate simple, low cost, safe, minimally invasive, that is double flange technique. So main instrument here is the low temperature cautery and 70 Prolene suture. So we describe here two approaches, that is ab interno from iris to sclera and ab externo, that is from sclera to iris. So this is the ab interno approach. This is animation come multiple picture. And this is ab interno approach.
Iridodialysis can be seen from 3 to 8 clock hour. A spatulated straight needle with 70 Prolene suture is introduced from the main incision parallel to the iris using needle holding forceps. This exits from the sclera approximately 1.5 mm from the limbus at 6 o'clock position. The proximal suture is cut, then flanged with low temperature cautery and pulled towards 6 o'clock. The distal end is also cut, leaving a stump of 1.5 cm. Next, in the same manner, now needle is introduced from 9 o'clock position. The needle is exteriorized at 3 o'clock position. The proximal end is cut, then flanged, gently pulled towards 3 o'clock position, and the distal end is then cut. In the same way, another needle is inserted from 11 o'clock, exteriorized at 5 o'clock, and the same procedure is repeated again. Now, all the three distal ends of the suture are gently pulled and tightened so that the iris appears flat. All the three distal ends are now flanged at the scleral end with the help of low temperature cautery. All the viscoelastic from the anterior chamber is now washed, anterior chamber is formed, and conjunctiva is opposed with the help of bipolar cautery.
This is the ab external approach. So needle is passing a sclera to the iris and then exteriorize suture using the Kugling hooks and then flanging the proximal end of the suture and then flanging the distal end of the suture. Then after that conjunctival closure. So why we choose double flange technique? Coming to the literature, the Kasaka et al. 2019, they use the 27 gauge needles, pre-flange, and they use the high temperature. But our double flange technique, we no need of any pre-flange, the sutures and extra needle or docking. And 2022, the Rosenberg et al., they also use 27 gauge needle with ab interno. But our double flange technique, no need of any needle docking. It can be done both ab internal as well as ab external. Peng et al. 2023, they use 30 gauge needles. Same years, Vivekananda et al., they also use 26 gauge needle, that is ab external approach. They use 60 Prolene suture and suture loop is lying, that is U-shape, lying over the iris surface. But our double flange technique, suture flange is lying over the iris surface and no need of any needle docking and can be done both ab internal as well as ab external. So advantage of our technique is very simple, minimal invasive, quick, subtle learning curve and can be safely done by our all cataract surgeon and can be done both ab internal as well as ab external. So this needle, thank you. So this needle is spatulated 30 centimeter gauge and the force is, that is 40 gram. So it is easily entered to the iris as well as the limbus. And compared to the 26 gauge needle and 30 gauge needle, that is we are conventionally use. So it is very, and the whatever is flange we are doing, that is very, very dot-like. Suppose the thickness is, it is 100 to 200 microns, and when we making the flange, it is 0.2 to 5. That's very less millimeters. And then, but iris thickness, that is 1.2 millimeters, millimeter is there. Then when we flange is there, no. So it is easily go and very stable also. And during the flanging, that where tightening is there, that should not be too much loose or should not be too much tight. Otherwise, more tight, that is easily come out. So that SFL we are doing slightly tight, but in the iridodialysis repair, we slightly take loose so that it stay flange is this side and outside also, so easily stable.
Good, very good. Any questions?
This will outscore other technique. Means, which type of dialysis do you think it should be really done?
Yes, sir.
Which type of dialysis you think it should be done? Will you do it for just 1 hour?
No, sir.
Clock hour dialysis.
No, any clock hour we can do, any on the right hand also, there is no problem. Left handed, there no need. Right handed, any side.
No, why did I ask you was, this double flange technique will be useful where your dialysis is large.
But here there is no problem. Ab internal, we describe both ab internal as well as ab external. Suppose it's not possible, then you do the ab internal also, sir. So
Any
that,
incidence of rise of intraocular pressure in the post-op period, and did you do goniotomy?
sir, all patient you have to do the gonioscopy to look any angle closure that is, and take the our IOP intraocular pressure. So with that, but we did till now 4 patients. All patients are good. Visual acuity is good, and there is IOP also normal, sir. And thank you, sir.
Thank you, Dr. Anjali.